All right. Sorry, I don't know what happened with the speak and everything. So I will just carry on because of the interest of time. I have no conflict of interest to declare, and I'm not affiliated to any drug manufacturer or anything that I'll be presenting. And this is merely for academic purposes, and the concept of the picture that will project is obtained. So just reflecting on the tonsillectomy, we are still seeing the increased trend of tonsillectomy because of many other reasons. And the indication being almost the same most of the time, recurrent chronic tonsillitis, obstructive sleep apnea, and others. And there's been associated over time, associated of a number of post-operative morbidities, and pain has been the big concern here. The same is encountered with adults. So recent publication have shown us there's about 50% incidences in children which is experienced in the first 24 hours, and this is ranging from moderate to severe pain post-operative. And when you look back into the previous literatures, which documented for 80% of incidences in the previous literature. So we can see how far we are moving, but still we have a big burden of this morbidity. And we tend to document or experience reports from patients that on the third and the seventh day, that's when mostly they report the pain. And after they have been discharged from the hospital, the burden of pain management really is on the parent and the child's own care. So these four are the most prominent or most reported post-tonsillectomy morbidities, ranging from pain, bleeding, otalgia, and time taken to resumption of normal diet and daily activities. So over decades, tonsillectomy morbidity management has been a great topic in many places around various specialties. And this has resulted into the inventions and people looking around to see how far we can go through this challenge. And this ranges from the multimodal pharmacological management approaches down the way to tailored approaches for patients with specific comorbidities. So I'll try to go in briefly on each component on the categories so that to build a block on what I will discuss later. Looking really on this topic, I will concentrate on the local anesthetics, and this is why we are here. So looking on the multimodal pharmacological management, a lot has been reported, and I'm just projecting few papers to just show the concern of what has been happening around. So Michael and colleague did a good scoping review on a number of clinical trials, trying to look around how post-tonsillectomy pain management has been developed and has been reported to the concern. And they found out, despite all this pharmacological management, there's still a gap of how much we have won. And this includes to the obvious common acetaminophen and ibuprofen. So they recommended for further follow-up to see which oral medications, including the ones we have on the table, can help us solve the challenge. Looking on the intraoperative techniques, all the ways from when Prof. Fagan was practicing to today, there's been a lot of invention. If you look, Giriton, cold steel, electrodissection, and compression, many have been looked into trying to tackle around the problem. And these few studies have shown, despite what we have having in back of our mind, still there's a challenge with different modalities. So the modalities really don't give us a good answer for a majority of managing these challenges. And not surprisingly, but fair enough, the Cochrane did their review in 2017 in regard to coblation, which many people have thought that it is a significant decrease in pain post-operative, and they found those the difference was small in terms of clinical relevancy, and it didn't make any meaning. So this gives us a highlight call that why shall we invent on it's fine to invent good technologies, but if we can think of something which is available and accessible to everyone, we can start to think now of topical anesthetics. So bupivacaine local infiltration has been done over decades by the orthopedics, the general surgeons, and the like, including the dentist. And its role and techniques has been discussed. And of recent, the content of its potency has been documented more, and because of many other factors, including accessibility and safety, it has been advocated in many practices. So this is just to start the discussion with a paper from Huagong and the colleague. So they looked on they did a meta-analysis to see if there's an efficacy of bupivacaine and alike for post-tonsillectomy breeding. And they found that the administration of bupivacaine is recommended during tonsillectomy, as it reduces the perceived pain as well as the post-operative morbidities. So bupivacaine has been common and was identified in 1950s, and is one of the, on its group, it's one of the powerful local anesthetics. It's been used for local, regional, epidural, and then local infiltration, as we are discussing here. And its function has been straightforward. It will just delay the electrical impulses, and then it will have a longer potency. Commonly, there are three formulations mainly for their concentrations. So commonly we use the 0.25% and 0.5%. I will explain later in the dosages. Its roles has been from reducing the onset of postoperative pain and associated morbidities, all the way to encouragement of these subjects to feeding in terms of postoperative. And if you look on the literatures, you find out people have documented that it is a very good potency with within the first, second, 6th, 24th hours. And at the 7th day, many patients report a very good outcome. And its longer duration of action, this helps us to consider it further, being one of our good options. So in terms of dose and precautions, we have different formulation, as I said before, but the 0.205 is preferred for children, and as the anesthetists have been using it for a long time. So 1.5 milligram per kilogram body weight, but that will give you a huge volume and a maximum volume of 2 mils, and you inject 1 mil on each side, which I will show later how to do it. And in adult, the 0.5 is preferably, and 1.5 mils on each side. So the higher dosage, why we advocate for specific these doses, this is depending from what has been done and reported from our colleagues elsewhere in the world. And if you increase the dose, it means you are also putting the chance to anticipate more adverse events, including cardiotoxicity and seizures. Assessment of our patient should be very important. You don't have to ask it just on the table because you have seen it. Assess your patient beforehand, during your admission or something like that, before they are put in the sleep. And don't forget to identify all important and possible contraindications, as this is the medication like other medications. So if you recall our anatomy, our palatine tonsil gets a good supply and innervation from the glossopharyngeal nerve, and the glossopharyngeal nerve has three components, as it's known, for the sensory fibers, motor fibers, and parasympathetic fibers. In concentrating on the soft sensory fibers, we are interested more on all the four parts of the sensory fibers, and the palatine tonsil is really a concern here because of it's subject to management. So we have two approaches. We have either intraoral approach for the glossopharyngeal nerve block, or we can use the extraoral approach. And for the benefit of all the audience, I will dwell more on the intraoral approach, which is done by the operator or the surgeon, and the rest is the other one is done by the anesthetic. Mostly ultrasound guided. So the intraoral technique has two approaches. The first approach is basing on the paratogrossus fold, where your injection is all marked around the paratogrossus arc. And the second is the paratopharyngeal fold approach, which the paratopharyngeal arc is used as a landmark. And this is the most preferred because of the anatomy and the innervation of the palatal and tonsils through the glossopharyngeal nerve. So what are our requirements? I've put this picture so that to tell. We have two different preparations. We have bupivacaine with epinephrine, and we have bupivacaine, plain bupivacaine. And in this context of discussion, I'm basing on the bupivacaine without epinephrine. And please always ask this question, because we ask this medication from the anesthesia, and have the right medication because of the anticipated challenges that might encounter. We tend to ask to use for the Lualoc syringe because of the safety in terms of needle handling, and we prefer to use either of the three needles, the 22 gauge all the way to 27 gauge, and for the 50 millimeter. Try to avoid not to use the longer needles, because they have high chance to hit other adjacent structure, which you don't intend to do. And remember the anatomy of the phalanx in relationship to the posterior pillar and the internal carotids, and all alike. So intraoral technique, this is a picture of our patient in supine just immediately after you have done your tonsillectomy. You have to get your medication from either from the anesthetist or on your surgical table prepared beforehand. And what we will do, we will inject, as I said, the preferred mode is the posterior or the paratopharyngeal arc, and just go the last 1/3, I mean the inferior 1/3 of your arc. Bend your needle in half from the half point of the needle, and make sure when you are injecting, you go into this muscle close to the base of the tongue, aspirate to make sure that you are not hitting any other vital structure, including the vessels. And then if you are safe, start to inject your medication. While coming up, you will see there will be a bleb of deposition of this medication. And many people, or the practice has been to inject both pillars after your tonsillectomy. Remember, there could be some pitfalls, including the bleeding at the injection site, which can be easily controlled by either gauze compression or by bipolar. So these are my references, and this is just to remind every participant for our joint congress here in Cape Town. Thank you very much.
Thank you, Denis, for a wonderful talk. Do we have any comments from the audience? Or...
Could I make a comment?
Yes, Buffy, you can go ahead.
Denis, I'm not that old. You made a comment. This is my day. But just two issues. The one is that that the recovery nursing staff at the private hospital that I worked at, they commented that children often were quite panicky when they couldn't, when they lost sensation in the pharynx in recovery. So it'd be interesting to hear from if there are any anesthetists on the call as to whether they think that might be a problem. in terms of aspiration and airway safety after anesthesia. And the other is I'm interested to see that you say the effects could last up to 7 days. How do you explain that?
Thanks very much, Prof. And thanks for the comment. So the first part in regards to recovery. So studies have found also that patients who have received bupivacaine, they have less chances of delirium during recovery, contrary to the counterparts. So we have less documented delirium post recovery, and to date, for the studies that we have reviewed, we have not documented, especially from the systematic review, any challenge which has been associated with seizure and alike. And the second point, the second question in concern with the 7th day, here they looked on the effect of the bupivacaine in terms of taking care of the morbidity, the comorbidities associated with tonsillectomy. And on the 7th day, it is reported that because these children and patient starts to eat very comfortably within the first 72 hours, and they tend to drink further, and this pull the effect of recovery at the 7th day.
Yeah, are there many good prospective studies, or are most studies retrospective? Because I always think that the procedures like grommets and tonsils, we do so many of them, and there must be so much opportunity for doing some good prospective studies at Red Cross Hospital. Do you think there's a need to do some more prospective studies around this whole issue?
Yes, Prof. There's a documented a good number of well-designed RCTs, many parts now. In Tanzania, in my institute, we are analyzing the data from my PhD study in regards to bupivacaine, and we will share these results as soon as we finish. And it's a good double-blind randomized control trial where we used bupivacaine, lignocaine, and saline. So there's still a lot around to adopt. We have started to do bupivacaine block in Red Cross after we discussed and shared evidences with Prof. Shazia. And recently also Jesse is applying the same modality in Mitchell's brain. So I think there's a big knowledge around this topic.
Thank you, Denis. Is there any more comments from the audience? Questions? Well, thank you, Denis, for a great talk. If there are no more questions or comments from the audience, we'll end for today. And we'll see you next week. Thank you.
Thanks. Bye-bye.